I also would like to thank Ravi and the other organizers for inviting me in spite of coming from the extra obstetric planet of radiology. I am well aware what you are thinking of radiologists. I think this, but you might not be aware what radiologists think of you. Okay. Well, there are prejudices of obstetricians against radiologists, and most of them are true. Radiologists know nothing about fetuses, don't know what's important, write ununderstandable reports, are busybodies who want to lure patients away, they would if they could, and think that MRI answers all questions. No, because then they would be responsible, and the responsibility is, of course, with you. Now, coming into facts, ultrasound for obstetric purposes has been around about 40 years and MRI only about 25. There are 3 levels of qualification, at least in Europe, you know that. And do you know what qualification you need as a radiologist to be able to do fetal MRI? Well, you have to have access to a magnet. And this sounds funny, but this is really a problem because this is responsible for the big differences in image quality you get when you order a fetal MRI. And of course, ultrasound can be done early in the first trimester, and we are not good with MRI to date before gestation week 17 or 18. You see, we see something, but not more than ultrasound. And of course, you have the Doppler, and we have very limited information about vessels and perfusion. So, how do you know that you look at a good quality MRI? You need to see at least 20 sequences. What is a sequence? A sequence is a choice of parameters that influences signals and resolution, and if you are happy, you have such a sequence acquired within 20 seconds. And then you will ask me, well, but if it is so short, then why do you need at least 20 sequences? Well, as you know, fetuses are moving, and you are not always that lucky that you really get a sequence that is beautiful enough, so you have to repeat it. And of course, and it's because of the repetitions you end up with at least 20 sequences because you need orthogonal planes of every organ. Different planes and contrasts are important. What does that mean? I just show you examples. Of course, most of them are still black and white, but as you see, different organs are here demonstrated differently. Here, for instance, you see the bowels on T1, and here you see tracts, and here these points, these yellow points, are signs of brain activity, and other sequences do not lead to morphological images, but just to graphs like this, such as spectroscopy, and when we do perfusion, we end up with images like that. So if you have a big choice, a lot can go wrong, of course, I will show you that. Because you need to choose the appropriate sequence for the question and also the appropriate slice thickness. So these are different names for the same sequence, and some radiologists are using this sequence for everything. So you will tell, so what? I can see the brain in 3 planes. What's wrong with this sequence? Well, nothing, except you want to find galenic malformations, because this sequence is not the sequence that can be used to show flow in vessels. So I just wanted to show you that a lot can go wrong when the sequence is not used correctly. And you have to adapt the parameters. You don't have to read everything that is written here, but just compare. Here I see the aqueduct and I see the chiasm, and here the parameters have been chosen wrongly, and I cannot delineate these small structures. of course, after Professor Benoit's presentation, we don't need to see them anymore, so just forget it. Slide thickness 1 millimeter. When do we need this? This is rather thin for MRI. As you see here, septum pellucidum is missing. Next question is, what does the chiasm? And here we have the opportunity to go to 1 millimeters, which is usually enough to, to look at the chiasm. But I think ultrasound is much better, and Gustavo will you show in the afternoon how much better it is. It has become in the meantime, but here you see a hypoplastic optic chiasm. Well, next thing is good image quality. What does that mean? Compare. This is a much better image than this. Why? Because in MRI we are using coils. And I will show you in a minute what this is. And if the coil is an appropriate coil, we will have much better image quality than it is not. And this is a small device that we can use in most instances, except in late pregnancy weeks and when the pregnant woman has a bad body mass index. And these are examples for such coils. These are devices that are placed on the maternal abdomen, and here the signals are received. Well, this is especially important when you use so-called diffusion-weighted images. Look at this and look at this. I get always angry emails. Daniela, you sent the wrong parameters for the sequence because they don't work. Well, if the coil is not in the region of the head, they cannot work. And here, this is just a drawing. These are the receptor elements of the coil, and of course you want to have them as close as possible to the region of interest. This is rather easy in earlier pregnancy weeks than in later ones where you have a lot of fluid. And a bad situation is a late pregnancy week where the head is engaged in the pelvis because there are no coil elements placeable near to the head. So if you really want to send a patient with a brain question, you are better off doing a transvaginal ultrasound. Well, the whole fetus and the extrafetal structures have to be examined. Why? Because there are different species of radiologists. One that are neuroradiologists and the others that are pediatric radiologists. Neuroradiologists look at the brain, pediatric radiologists look at all the other organs. Doing fetal MRI, you have to look at everything and also at the placenta. I'm showing just one example. This is a really bad looking brain. Why? You have on the different contrasts, you see there is blood, there is destruction of the brain, and also blood in the extra cerebral spaces. And the next question is, why did this baby bleed? And if you only look at the brain, you would not learn it. But if you see subcutaneous edema, cardiac effusion, and an edematous placenta compared with the normal one, then you know this is fetal inflammatory response syndrome, and you are able to screen for the background. Normal brain development. Finally, let's go to normal brain development. You know the brain parenchyma goes from thin to thick. It goes from smooth to structured and from layered and disorganized to regionally organized and connected. The parenchymal thickness is increasing, and we know that because the ventricular size is not much increasing. This is nothing new, but it proves that it's really the brain parenchyma that increases in thickness, and Gianluigi already showed this series of images where you can see how the cortical folding proceeds over gestational weeks, and it is almost major at gestation week 35. We can see that also in sagittal planes. Here you also see the growth of the corpus callosum and, very important, the cerebellum, and you should be able to see the primary fissure around gestation week 24 at least, if not earlier. Coronal slices show you mainly the development of opercularization and the development of the temporal lobes. We have landmarks on the surface. You can read this. It's really boring to go through all these landmarks, but what we found out a long time ago is that the hemispheres do not develop at the same time, that, for instance, the right temporal lobe develops normally much faster than the left one. And we could prove that doing a model, a computerized model, where we marked the surface of the hemispheres and then separated the hemispheres, and the computer calculated the differences between the hemispheres, and this is a sped up fashion, and what you can see is that the right temporal lobe really develops faster than the left one. And I will show you later how we use that. So we see that even before gestational week 24, that the left has the shape of the C and the right has the shape of an L. And of course, we can also look at the hippocampus, at the development of the hippocampus, that in adults and major fetuses has a position parallel to the temporal horn, but earlier has a position that is perpendicular to the temporal horn. And I know these images are blown up and unsharp, but you can see here it is perpendicular and here it is already parallel, and here you have the comparison with pathology. But it's not enough to look at the surface of the brain, because we know from histology that the brain has a laminated appearance until gestational week 30. Here we can see the ventricular zone with its ganglionic eminences. This is the zone where all cells are generated, neuronal cells and also glial cells. Then we have the very important subplate, where transient connections are made, and the cortical plate that does not have a lot of function before gestation week 30. And then we have other layers, such as the subventricular zone and the intermediate zone, this being the beginning of white matter. This is from the work of Ivica Kostovic, who described the subplate in detail, and you have here what he described. And what is most important is the integrity of the subplate is crucial for normal cortical development. What does it mean for you? It means if you read a report about a fetal brain before gestation week 30, the lamination and especially the presence or absence of the subplate has to be addressed. Otherwise, you have to consider this report is not complete. Well, radiological signs of abnormal brain development in the second trimester. I cannot discuss everything, but as I saw that especially the premature onset of sulcation and gyration is covered by Gustavo by ultrasound. So let's look at these. Missing subplate delineation. Well, you see this left hemisphere is clearly pathological. You can delineate the subplate on the right hemisphere, but not in the left one. And you will tell me, well, I don't need to see the subplate to see what's the matter here. Of course, you see this is hemimegalencephaly. But in some cases, it is helpful. Look at this. Lissencephaly, we looked at 26 cases in the second trimester, and 60% had pathological lamination. This is a case with the normal subplate, and here this is a case of lissencephaly with really a very small subplate on T2 and on diffusion-weighted sequences too. Insular indentation, it was already addressed. This is 24 gestational week, no insular indentation. Well, there are a lot more things pathological in the brain. And the good thing was, until some years ago, we just called this a full-blown picture of microlissencephaly. Do you know how we call it today? Well, I will tell you, you have to learn it by heart, and I cannot remember it. It is called a malformation secondary to abnormal neuronal and glial proliferation or apoptosis. You know where this comes from. It comes from a summer that Jim Barkovich spent with Charles Rebaud in Marseille. And there they cooked this new classification, which is really awful from the radiologist's point of view because you cannot remember anything anymore. You always have to read the new paper. Another example, the Seckel syndrome, you know, the bird face, also here, missing insular indentation. Brain asymmetry. This is a fetus in gestation week 20 with the right and the left temporal lobe having the correct form of an L and a C. And if we look at this one, you see there are two C's, and this is one sign of, listen carefully, type 1. Because, of course, you always ask us in a stage before the onset of gyration whether we have, listen carefully. So we have to diagnose listen carefully in an almost listen carefully stage. And this is why we came up with this right and left brain development. And we found it that in about 60% of our listen carefully cases, we found that there was really asymmetric, mirrored asymmetry or pathological symmetry. I just put the stomach in there so that you can be sure where is right and where is left. And what you see here, of course, there is a bump that should not be here in gestational week 24. So this is also premature onset of gyration. And in addition, we found in a high percentage of corpus callosum agenesis cases abnormal hemispheric asymmetry, and I can show you what we did. We did the same investigation, and you see the difference between right and left is not as pronounced as it was in the normals. So pathological asymmetry is also a feature that we use for early diagnosis, and if you have good images, you can look for that yourselves. Well, now I'm forced to explain to you diffusion-weighted imaging. I think that's why Rabbi gave me 45 minutes for this talk. Well, if you want to have a drink, you will understand what it is, because water protons move quite randomly when there are no obstacles. We call that isotropy. Yes, if you drink water or even coffee, you drink isotropic water protons. If the water protons move within a structure, as for instance an axon, they are slowed down perpendicular to this direction, but they may freely move in this direction. And as when their movement is restricted, they give signal. And this is the base for diffusion-weighted imaging. And I will show you, these are examples, gestation week 22. This is the diffusion-weighted image. This is the underlying T2-weighted image. And if you subtract the T2 effect from the diffusion effect, you end up with so-called ADC maps. Perhaps you read it already. It's called the apparent diffusion coefficient, and this is pure diffusivity. So, okay, let's go into practical cases. I think it's easier. This was a case, gestation week 36, very bad Doppler values. Doppler values going down within 1 day. And you see this is the T2-weighted image showing nothing. Diffusion-weighted image showing a bright spot, and this is correspondent to very recent ischemia, which you would not see with any other method. Why do we know that? Because we know that from our postnatal cases where we use diffusion-weighted images for the proof of recent ischemic infarctions already for about 20 years now. But now let's look at anisotropic diffusion-weighted imaging, because the corpus callosum is a structure that may restrict proton movement, and it does it in a stage where it is not yet myelinated. For instance, gestation week 26, we have sagittal images, coronal images, axial images, and here we have a case where we only see a knee, which would be really difficult to find using T2 weighted images only. And the whole thing, this so-called anisotropy, is the basis for doing tractography. Because this white matter anisotropy, as I have to emphasize, we see it in non-myelinated axons, and almost all of the supratentorial axons are unmyelinated during pregnancy. And the reason is because a membrane potential electricity precedes myelination. This is an example for tractography. As we see the main connectivity in gestation week 23, what do we see? Blue, the corpus callosum. This is the corticospinal tract, and this is the sensory tract, the frontopontine tract. In later gestational stages, we see more tracts, and we even see the uncinate fascicle in the inferior longitudinal fascicle and the superior longitudinal fascicle. And you know, for instance, the uncinate fascicle connects the regions that are responsible for language. And so we really want to have these informations of these tracts, because we hope that in future we will be able to give better prognostic counseling because of the proof or not not the proof of these tracts. I show you one example because this is not science. We using tractography all the time. You see this is hydrocephalus. You see the corpus callosum is missing. And then you see that there are corticospinal tracts, because what you think this may be lichen-worn malformation X-linked hydrocephalus, but as you know, in X-linked hydrocephalus we don't have corticospinal tracts. So using this, we can exclude this condition. Of course, we cannot exclude others, but at least this. Well, let's go back to brain anatomy. The ganglionic eminence, I already told you. Here we see it on T2, and also on diffusion-weighted images and on the ADC maps. It's rather cell-dense, and this is the origin of all cells. Why are we interested in this? Because these ganglionic eminences have a microstructural geometry. Until now, I showed you that we could follow the white matter fibers. But of course, the machine does not distinguish between white and gray matter. It only follows structure. And if the structure has the shape of a fiber, it will find fibers. But in this case, it is pseudofibers. You're looking at me not knowing what I mean. Okay, I remove everything that may confuse you. So I remove all the white matter fibers, and we end up with this. So these are pseudofibers. Here we have them in a 3D fashion, because this is the path of tangential migration. You know, usually most of the neurons migrate in an inside-outside fashion, in a radial fashion, but there are neurons coming from the basal ganglia that move in a tangential fashion. And here we can see them. But why are radiologists interested in that, and why should you perhaps be interested in that? Well, because this is the development of cortical GABAergic innervation. GABA is an inhibitory transmitter, and there are pathological conditions where all these neurons stay in place, and also the GABAergic transmitters stay there, and this condition is lissencephaly. You see it here, and I have also an example with pathological confirmation. If you see persisting ganglionic eminences like that, you know there will be a problem with inhibition. And if there is no inhibition, what happens? Epilepsy. And perhaps this might be one of the reasons why these children are so prone to develop early epilepsy. I don't say it's the only reason, but it might be one of the reasons. Okay, let's move to T1 weighted contrast. T1 weighted contrast, don't look at this. We just playing around with parameters, and what you should see, it makes a difference, for instance, in the brightness of the basal ganglia, which parameters we use. T1 weighted images give a bright signal in the pituitary, as you can see here. In regions that are very cell dense, as the basal ganglia, and of course myelinating structures are bright too. What about pathology? Hemorrhage in the stage of methemoglobin is bright. Of course, also venous thrombosis. Calcifications may be bright, as you can see here in this CMV case, and fat. And there was a discussion when fat changes the impedance on ultrasound. What I can tell you from MRI, fat does not become bright before gestational week 28. Before, it is just dark as all the other structures, and this can be difficult if you look at the spine, of course. Echoplanar sequences are the sequences that are most sensitive for certain blood breakdown products, such as deoxyhemoglobin and hemosiderin. You see these are so-called echoplanar sequences showing you all these dark blood breakdown products. So if you look for blood, an echoplanar sequence has to be part of the program, otherwise you will overlook hemorrhages. I just show you a development of an intraventricular hemorrhage here, bright on T1 weighted images, also on diffusion. Here you have the T2 with lesions, and this is a follow-up, in beginning of the gestation week 34, and you see here on the so-called echoplanar sequence, you still see the blood, even if it has almost gone on your conventional sequences. Okay. From your faces, I can read, you will leave the reading of brain development on MRI to radiologists. However, maybe you want to order a fetal MRI and you want to have a successful report. So the last part of my talk will be about how do I order a fetal MRI, a useful fetal MRI. So first thing is, what do I want to know? Next thing is, what informations can be received at what age? And I'm just referring to second and third trimester, because in the first trimester we are not good enough. So, second trimester and third trimester. This is really very important to keep that in mind, that there are probably things you won't be able to find with MRI in the second trimester. Let me show you an example. Gestation week 22, suspect tuberous sclerosis because of a rhabdomyoma in the heart. This was, of course, not the primary MRI diagnosis. It was an ultrasound diagnosis, and the MRI was asked to look at the brain. I know these images are not the best ones you have ever seen, but they should be good enough to look for manifestations of tuberous sclerosis. And as you know and I know, there are a lot of publications, of course, case reports, not case series. We have diagnosed tuberous sclerosis with MRI in gestation week 18. Well, yes, tuberous sclerosis may have changes that are large and involve large parts of the hemispheres. Then you see it with ultrasound, with MRI, with palpation, with everything. So we didn't see anything, but the patient came back in gestation week 36, and now here it is. Subependymal nodules, tubera, and even kidney cysts. So, some things cannot be seen earlier. It does not mean it's not possible to have an earlier diagnosis, but the full-blown picture may evolve only later. So, MRI when? This is just a very short statistic when we do it in Vienna. we do about a quarter of cases before gestation week 24. The reason is because in most European countries, the border of legal abortion is gestation week 24, so we have to try everything. Of course, the Scandinavian countries have it gestation week 18, so they have for a long time not be interested in fetal MRI anyway, which I can understand. Next peak is here, gestation week 27 to 29. Why? Because here we get the best side on organs, and we can tell a lot about the prognosis, and the woman can still be in the magnet without problems because the belly is not that large. And the last group is here around gestation week 33, and this comprises those cases that would have to have a postnatal MRI, but if they have a late prenatal, for instance, in myelomeningocele, in conditions that have been surgically treated right after birth, they spare the postnatal MRI when we do immediately one prenatally. So just to give you short information, from gestation week 18 onwards, you should be, there's a C missing, you should be able to diagnose lissencephaly, and most holoprosencephalies, well, Gianluigi will say, I don't need MRI to diagnose holoprosencephaly. Yes, I said most, yes. But if it's just, if it's lobar, or if it's just that a sulcus is connected that will develop later, it might be difficult. And before gestation week 24, lissencephaly type 1 and commissural agenesis, aqueduct stenosis and obliteration. You will ask me why lissencephaly 2 and not lissencephaly 1. It's not because the C is missing, it's because of the brainstem. Yes, because in lissencephaly type 2, the brainstem is always malformed, and I will show you that later in the afternoon. In the third trimester, you see post-migratory changes and anytime hemorrhage or infarction. So, how do you have prepared the pregnant woman? And here I would like to show you some facts of a study we did a time ago with the Department of Psychology, because we wanted to know how much the women know before undergoing an MRI. And we asked them, how do you expect the MRI procedure to be? Well, I don't know. I suppose that I have to lay down, but I don't know exactly. I know nothing about it. They said it would be in a tunnel, and they asked me if I would be claustrophobic, but I saw MRI in TV. So either you talk to your patients or you tell them to look TV. Yes. The next thing is the positioning of the pregnant woman. Also here we did a study where we put 57 patients in supine position, and we measured the compression of the vena cava. And here you see the compressed vena cava, and there was, in about 3/4, severe compression of the vena cava. So, how many % of the patients displayed symptoms according to cava compression syndrome? What do you think? No, presented. What? Because it was a biased study. Because what we did, you always think radiologists don't talk to the patients. We do, because we asked the woman, how can you stay half an hour? Is it better on your back or on your side? And if she says it's better on my back, we put her on the back. Or if she says I'm sleeping on my back, so we put her on my back, because it's really very important that the woman is in a position where she can really stay relaxed. Okay, no fetal MR examination. Of course, there are absolute contraindications. Claustrophobia, you can use sedation. We usually don't use sedation. I know in France they usually do use sedation. Or when the parents will not draw any consequences, but it does not, so it doesn't make sense. And there are a lot of pregnant women that feel as a vomit, a victim of modern imaging technology, so you should not force them to undergo MRI. And preparation. You should inform your patient about the indication, possible consequences, the course of the examination, and it should be done by the obstetrician, the midwife, a psychologist, but if it's possible, not by us, because this is too short before the examination, and the woman will be like this and not get any information anymore. I would have a lot more things to say, and I will do it, but not here, but in Vienna. So please come to Vienna in June, and if you really want to do fetal MRI, we have a practical workshop also. What does it mean? You sit near the magnet, and the radiologist assistant sits near you, and you have a fetus moving in the machine, and she asks you, what should I do now? And then you can try. But I have to warn you, from our experience, the workshop is very early sold out. So please come and register. Thank you very much for your attention.